So we started from the real basics, and now we're going to conclude with, um, I don't want to say the most difficult area, but the area in hypertension that you have to be more aggressive. You have to know what you're doing. Um, so we're going to continue with the treatment of cerebrovascular disease. When we talk about cerebrovascular disease, there are multiple types, and you have to take into consideration the type of stroke you're talking about. Is it a hemorrhagic stroke? Is it an ischemic stroke? And then the acuity of the stroke. And then the therapeutic objective is going to vary with the acuity and the type of stroke. So let's look at acute cerebral hemorrhage. That is, you have a bleed in the brain. If you have a cerebral bleed and the systolic blood pressure is above 220, you can treat it above 220, but between anything less than 220, you don't want to treat it because the brain is such that in that acute situation, it needs that high pressure to perfuse the brain. So unless the systolic blood pressure is greater than 220 millimeters mercury in the acute setting, you don't treat acute intracerebral hemorrhage. Okay, it's very unnerving when you're in the intensive care unit and you see the blood pressure 210 over 100. The knee-jerk response is to treat, but you can make the patient worse. So remember that. Systolic blood pressure above 220, you don't want to treat. If it's greater than 220, then you can treat to bring the pressure down to under 220, but you have to use intravenous drugs. Do not use PO medication for that because you have to titrate the pressure. All right. So this is a little chart sort of giving you an idea of what to do. So in the acute setting, that is less than 6 hours from the onset of symptoms, if the patient have a spontaneous intracerebral hemorrhage, blood pressure greater than 220, if it's greater than 220, you can lower the pressure to bring it down to below 220, but you have to use intravenous drugs. You have to titrate the pressure gradually downwards. If you give oral medication, you come back 2 hours time, the blood pressure may be 150 over 80, and then the brain is not getting sufficient perfusion. So be careful of that. In the acute setting, you don't want to do that. You definitely don't want to lower the blood pressure, systolic blood pressure below 140. So remember that, intracerebral intracranial hemorrhage. All right. So what about ischemic stroke? So when we talk about strokes, it's either bleed in the brain or there is an occlusion to the blood vessel. At any rate, the tissue or the brain substance distal to the obstruction is not going to get any blood. Okay? So therefore, that brain tissue is going to die. Now, we're talking about an acute ischemic stroke. People who are doing the exams, this is crucial. This occurs in all the exams, all medical exams. If the patient presents in an acute fashion and the patient is eligible for TPA, so if it's an acute blood clot, we can use clot busting medicines to break up the clot. If we bring the patient in early enough, we can use clot busting medicine, break up the clot, and the patient will suffer minimal deficit. Okay, so in the different hospitals, they'll talk about stroke alert, because once a patient gets to the hospital in a timely fashion, you can give them clot busting medicine called TPA. but the blood pressure have to be less than 180/110, and this commonly occurs on the exam. They'll probably give you an elevated blood pressure and ask you what to do. Okay, you cannot give TPA or any clot busting medicine if the blood pressure is greater than 185/110. You have to slowly lower the blood pressure. And not only that, but for the next 24 hours, you have to keep the blood pressure below 185/110. Very important. Okay? And once the patient is stable from a neurological standpoint, then you can treat the blood pressure above 140/90. But if the stroke is still ongoing, stroke in evolution, you don't want to treat the blood pressure. Okay? All right. So in an acute setting, that is less than 72 hours from the onset of symptoms, the patient have evidence of ischemic stroke or elevated blood pressure. So when when the patient with a stroke goes to the emergency room, they say stroke alert, and basically what they're doing is alerting all the team, because that patient have to rush to the CAT scan. They have to get a CAT scan within a very, very timely, as soon as possible, because you have to make sure there's no bleeding in the brain. Once there's no bleeding in the brain and the blood pressure is below 185/110, then you can give them the clot busting medicine. So acute stroke less than 72 hours. If the patient is a candidate for the blood clot, the blood busting medicine, that is TPA, if they're a candidate for that, then of course you have to make sure the blood pressure is below 185/110 before you give the thrombolytic drug. We call the TPA thrombolytic drug. And then you're going to maintain that lower blood pressure less than 180/105 for at least 24 hours. Okay, so that's very important. If the patient presents with a blood pressure, so if they're not a candidate for clot busting drug and the blood pressure is greater than 220/110, you can gradually lower the blood pressure in the first 24 hours. Just gradually do it. If the blood pressure, however, is less than 220/110, then you want to stabilize the patient first. You don't want to treat that high blood pressure for the first, say, 72 hours. Okay? So you have a little leeway. All right? So don't be too aggressive in lowering blood pressure in patients with acute ischemic stroke. And again, people doing the exam, what the number they want is 185/110. You have to get the blood pressure below that number. All right. So again, if the patient is eligible for TPA, that's the clot busting medicine, you have to get the blood pressure below 185/110. Slowly lower it. You have to keep that blood pressure below 185/110 for at least 24 hours. And then if the patient is stable from a neurological standpoint, you can treat blood pressures above 140/90. Again, we talk about the acuity, the acute stroke. You want to be a little less aggressive, because the brain regulation, the regulation of blood flow is disturbed. So we have about close to 1 million CVAs, strokes per year, 750,000 to be exact. And a lot of those strokes are recurrent, 25% are recurrent. So once you have a patient who have had a stroke, they can get another one. So that is why you have to be aggressive after the acute event to reduce, lower the risk factors. You're going to treat these patients' blood pressure. You're going to make sure that the blood pressure is well controlled. And again, the first line medicines that you're going to use is diuretics, ACE inhibitors, and ARBs. Randomized controlled trials tell us that those are the medicines that are beneficial. So secondary stroke now. So the patient they have had a stroke before, and you want to prevent the next stroke. So in addition to the first line medicines we just mentioned, you can add a mineral corticoid antagonist, something like your aldosterone or eplerenone or calcium channel blocker. Okay. If the patient um, had a lacunar stroke or lacunar infarct, you can treat the systolic blood pressure to less than 130. Okay. All right. So this is the recommendation as presented in the journal. So basically the same thing that we have been saying. So class 1 indication, level of evidence A, adults with previously treated hypertension who experience a stroke or CVA should basically, if the patient have had a stroke and they're hypertensive, just put them back on the medicine, the class 1 medicine, and then you can add on. Okay. As we said before, you want to do your diuretics, ACE inhibitors, ARBs. You might want to use a mineral corticoid antagonist. So, okay, so we talk about stroke prevention. Okay, all right. So after 72 hours now, so the patient have had a stroke, and after 72 hours, if the patient had hypertension before, okay, if they known hypertensive, what you're going to do, you're going to just put them on antihypertensive medication. You just put them on your medicines, okay, and you want to make sure. So this is a secondary prevention now. You want to reduce the blood pressure below 130/80. Okay, you can plug them into the risk calculator, but they're going to be high risk. So the aim is to get the blood pressure less than 130/80. If they're not known to be hypertensive, then your goal can be 140/90. And of course, you're going to use your non-pharmacological strategy as well. So patient with peripheral artery disease, so patients who are evaluated, they have a blockage in one of the leg vessels. You treat them just like any other hypertensive individuals, nothing. You're diabetic. So diabetes is a special category because, risk factors for coronary artery disease not only includes hypertension, but diabetes, mellitus, cholesterol, and all that sort of stuff. And about 80% of your diabetic patients are going to have hypertension. You can put them in the risk calculator, but diabetics are going to be high risk. So the goal is going to be less than 130/80. Remember what I said? Only 3 numbers you need to remember. 120/80, 130/80, and 140/90. So high risk individual, you want to get that blood pressure below 130/80. So, diabetics with hypertension, there's increased risk of coronary artery disease, heart failure, peripheral artery disease, stroke, and cardiovascular mortality is increased. So, there are a number of studies that show that you should try and get the systolic blood pressure below 80 or 85. The HEART trial, hypertension optimal trial, the UK PSD, and the ABCD trial. So these are all trials that show that you should get the blood pressure down. Again, you're going to use your atherosclerotic cardiovascular disease risk calculator. And again, you Google it. You don't have to memorize it. Google it, put in the information. More than likely, your diabetic patients are going to be high risk. So you're going to treat blood pressures above 130/80, and you want to get it below 130/80. So you're going to start with your ACE inhibitors, ARBs, calcium channel blockers, diuretics. And even more so if you're diabetics have albuminuria. If they have proteinuria, protein in the urine, then you definitely have to use ACE inhibitors or ARBs. So remember that. So we come now to resistant hypertension. A lot of our patients have resistant hypertension. What is the definition for resistant hypertension? So if three antihypertensive medication with complementary mechanism of action does not control the blood pressure, so the patient may be on a diuretic plus two other medicines, the blood pressure is still uncontrolled. Those individuals have resistant hypertension. Or if the blood pressure is controlled, but it requires more than 4 medication. Okay, so 3 antihypertensive with complementary mechanism of action. One of the medicines have to be a diuretic, however, and the blood pressure is still not controlled, resistant hypertension. 4 or more medication to control the blood pressure, then resistant hypertension. And 13% of the hypertensive population have resistant hypertension. Okay, so what are some of the risk factors for this resistant hypertension? Older patients, patients who are obese, chronic kidney disease, African Americans, and diabetics. When you have resistant hypertension, there is increased risk of heart attacks, strokes, end-stage renal disease, and death. Okay, so you have to be somewhat aggressive and make sure you treat these patients effectively. The reason why we spent a lot of time on the first 2 lectures is because you don't want to have a pseudo-resistant hypertension. You have to make sure that you check the blood pressure properly. You have to know what is white coat hypertension, and you have to evaluate the patient for these things. Make sure the patient is taking their medications properly. Some patients will tell you that they're taking the medicine. For some reasons, whatever reason, they're not taking it properly. So you have to sit down with the patient and do a thorough history and evaluation. If you do all of that and the blood pressure is really not controlled, then you have to look for secondary causes. And we had an extensive lecture looking at secondary causes for hypertension, primary aldosteronism, obstructive sleep apnea, kidney disease, pheochromocytoma, Cushing's disease, thyroid, went over all of those. So you have to try and improve medication adherence when you are evaluating your patients. Improve detection and correction of secondary hypertension. And then remember, you have to use medications with complementary mechanism of action. You're gonna start with your calcium channel blockers, inhibitors of the renin-angiotensin system. Chlorthalidone is common in the 3-drug regimen. So, remember chlorthalidone. In addition to spironolactone, to the multi-drug regimen, as a matter of fact, a lot of studies have shown that spironolactone gives significant reduction in the blood pressure in this situation. So I have a low tolerance pulling spironolactone. If the blood pressure seems to be uncontrolled, I'm going to use aldactone, because it has been shown to be very efficient in those patients. So the studies that showed the efficacy of spironolactone is the Pathway 2 trial, looking at the optimum treatment for drug-resistant hypertension. So it demonstrates superiority of your spironolactone over alpha and beta blockers. So I have a low tolerance for spironolactone, and then After that, you can use your hydralazine or minoxidil. Okay, so spironolactone should be above your vasodilators, hydralazine and your minoxidil. This is not a very, this slide didn't really project very well, but these are, some of the things that will give rise to a pseudo-resistant hypertension. Make sure the blood pressure is measured properly. Remember, we went over the patient should be seated, the legs should be on the ground, the limb should be supported, the right size cuff. But, other things that you should look into: obesity, physical inactivity, excessive alcohol ingestion, high salt intake. Patient may be taking non-steroidals, they may be taking amphetamine, decongestion. So in these patients, you have to sit down and do a detailed history, okay, the history. And then if you do all of that and the blood pressure, you don't come up with anything reasonable, then you can look for your secondary hypertension. Again, remember to use your aldactone, and then you can go on to minoxidil or your hydralazine. So again, common cause for secondary hypertension, we went over all of this. Kidney disease, so do your BUN creatinine. The patient may have acute renal failure, renal vascular disease, listen for a BROE, even though it's almost never there. But in a young female, it may be fibromuscular hyperplasia of the renal artery, or the patient may have atherosclerotic renal occlusion. Primary aldosteronism is fairly common, so you should look for that first and remember how you're going to screen those patients. Okay, your aldosterone renin ratio, obstructive sleep apnea, very common cause. Patient take 2 to 3 drinks per night. Yeah, alcohol can do it. Pheochromocytoma can occur, not very common. Cushing's disease, hypothyroidism, hyperthyroidism. So there's a whole host of stuff that can give rise to a secondary hypertension. Coarctation in a younger patient, age less than 30. Okay, so there's a number of stuff that can do it. Now, the more vexing hypertension problem is your hypertensive crisis. So when we talk about hypertensive crisis, there are two conditions that we're referring to. We talk about hypertensive emergencies and hypertensive urgencies. So you have to know the difference between these two entities. But they're both of them is what we call the hypertensive crises. Okay, so when we talk about hypertensive crises, well, it's hypertensive emergencies or urgencies. So when something is emergent, you have to deal with it right. When something is urgent, yeah, you can deal with it right away, but it's not as a vexing thing to do it right away. So the definition for hypertensive emergencies is when you have a blood pressure greater than 180 over 120, and there is evidence of new or worsening target organ damage. So the difference between urgencies and emergencies is target organ damage. So the patient comes with a blood pressure of 220 over 100, and they're a little bit confused, they're obtunded, target organ damage, the brain. Or they may come with that same blood pressure, but they're in heart failure. They may come with that same blood pressure and they're having angina, they're unstable angina, or they may have renal failure. So when you have evidence of target organ damage with elevated blood pressure, that's what we call hypertensive emergencies. And those patients need to be treated right away. those patients have to be admitted to the intensive care unit, not the general medical floor, the intensive care unit, and they have to be treated aggressively. All right. So when we look at hypertensive emergencies, the death rate is greater than 79%. A lot of these patients die if they're not treated appropriately. The median survival is about, this is supposed to be 10.4 months if left untreated. Okay, so these patients will die. So they demand immediate reduction of blood pressure. Patients have to be admitted to the intensive care unit, and the blood pressure should be lowered with intravenous medicine, not PO, intravenous medicine. You want to limit or prevent target organ damage. So elevated blood pressure and encephalopathy, patient is obtunded, okay, behave as if they're drunk. If there's evidence of intracranial hemorrhage, okay, acute ischemic stroke or acute MI, okay? So if the hypertension give rise, because the difference between getting a stroke, when you get a stroke, the auto regulations are disrupted and your blood pressure can go up as a result of that. But hypertensive emergency can give you intracerebral hemorrhage. It can give you an ischemic stroke. And there's a difference. So you have to know the difference. You can also get an acute heart attack from elevated blood pressure if it's not untreated. You can get heart failure, acute left ventricular failure with pulmonary edema, unstable angina, dissecting aortic aneurysm, and acute renal failure. So if the hypertension caused these things, you have to reduce the blood pressure quite aggressively. The difference between hypertensive emergencies and hypertensive urgencies, the patient have an elevated blood pressure, but there's no target organ damage. Okay, you have a blood pressure of 220 over 100, and your kidney function is fine. There's no evidence of heart failure, no chest pain. They may just not take their medicine for a few days or a few weeks. Okay, or they may be, eating stuff that they're not supposed to eat. All right. So many of these patients have withdrawn from or are non-compliant with their medications. So all you have to do is reinstitute or just intensify the therapy. And some of these patients, you have to treat their anxiety. I've treated a lot of patient anxiety in addition to their antihypertensive to get the blood pressure down. So some guidelines. Nicardipine, which is a calcium channel blocker, intravenous calcium channel blocker, may be better than labetalol for short-term blood pressure control. But you can use several intravenous hypertensive, antihypertensive medications. And what you need is a guideline, because you have to know when to use what, okay? All right, so this is basically what we've been saying. A blood pressure greater than 180 systolic and or diastolic greater than 120. If there is target organ damage, and we went over what we mean by target organ damage. If there's target organ damage, yes, then that's hypertensive emergency. Admit the patient to the intensive care unit. These are specific conditions now. If the patient have aortic dissection, severe preeclampsia or eclampsia, or pheochromocytoma, then this is the approach. You have to get that blood pressure systolic below 140 in the first hour. So the first hour is crucial. Intensive care unit, intravenous medicine, get that systolic blood pressure less than 140. millimeters mercury in the first hour. Okay. If it's aortic dissection, you want that systolic blood pressure less than 120, however. Okay. If no, then you can do it on a more gradual basis. So these are some of the medications, and you don't have to know all of them. People are doing exams, they have to know a little bit more about these medicines. Remember, nicardipine is a calcium channel blocker, and you know, we don't use a lot of it, but it's contraindicated in patients with advanced heart failure, and you're going to have to adjust for older patients. We don't use a lot of clevidipine. Sodium nitroprusside, we use a lot of this. Okay, so you have to know the problems. People are doing exams. You have to know the problems associated with sodium nitroprusside. We use a lot of this. This is very effective. However, tolerance. The patient can develop tachyphylaxis. They can develop tolerance to this thing. You can get cyanide toxicity with prolonged use. Okay. And if you get cyanide toxicity, irreversible neurological changes. So you have to know a little bit about sodium nitroprusside. Nitroglycerin, intravenous nitroglycerin, especially if the patient presents with heart failure, any coronary artery disease. So hydralazine, you know, we don't use that too much. It's used, especially in obstetrics and gynecology, but you know, in the intensive care unit, we tend to use bigger guns. Esmolol. So this is a beta blocker, beta 1 receptor blocker. We use it a lot in patients who have, you know, dissection. So you can use it in patients who you think will have a aortic dissection. However, be careful, you don't want to use it if the patient bradycardia or heart failure. Labetalol is probably one of the best antihypertensive medicine. You can use this in a wide variety of conditions. So, you know, you can use it in aortic dissection, any type of hyperadrenergic syndromes. Your preeclamptic patient, you can also use it. It's a beta blocker, so you don't want to, if the patient have reactive airway disease, you don't want to use it. If they have any type of AV blocks, you have to be careful. Phentolamine, I would probably want to remember this with pheochromocytoma. So, you know, P&P, we don't use a lot of phentolamine unless there is evidence of catecholamine excess. So, pheochromocytoma, monoamine oxidase inhibitors. We don't use a lot of felodipam. And enalapril IV Vasotec, we don't use a lot of it. You can know that it's there. So those are the medicines that we have available to use in the intensive care unit to bring the pressure down. Okay, and remember, you have to titrate the pressure down because you don't want to give them pure medicine and then you come back in an hour's time and the blood pressure is 100/50. They can get a stroke or some serious problems from that. One of the things that you have to appreciate is that in these hypertensive emergencies, the autoregulation of tissue perfusion is disturbed. It's not functioning normal. So you have to use medications that you can turn off the medicine and the effect will go away. Okay. Again, you have to know a little bit about these medicines. Okay. You know, if there's target organ damage, then that's emergency. Patient need to be in ICU, and you have to be using intravenous medicine. There are certain conditions that require more aggressive treatment than others. Aortic dissection, severe preeclampsia or eclampsia, and pheochromocytoma. As we said, you know, these two conditions, systolic blood pressure less than 140 in the first hour. Aortic dissection, however, You want to reduce that systolic blood pressure below 120 in the first hour. All right. So be careful. So again, aortic dissection. So the thing about aortic dissection, there's a rip, the blood vessel wall tears, and there's a shearing force. We call, when we say something shear, it tears it in two. So the shearing force is dp/dt, change in pressure with time. So if you change the pressure abruptly and you don't slow the heart rate, you can make the dissection worse. So patients with dissection or suspected dissection, you have to give them a beta blocker first, and then you can use a vasodilator, or you just use labetalol, because labetalol have both beta blocking property and alpha blocking property, and that is why labetalol is probably the best medicine to use in this situation. And again, you want to lower the systolic blood pressure to less than 120 millimeters mercury in the first hour. Okay. For acute pulmonary edema, I use nitroglycerin. So the thing about it, when you're practicing, you just need to know a few medicines that you can use, okay? And make sure you know to use those medicines very, very well. You know everything about those medicines. When you're doing exams, it's a little bit different, okay? Because they want you to know that you can use esmolol and labetalol in acute aortic dissection, pulmonary edema. The only medicine I use is nitroglycerin. Occasionally, I'll pull for nitroprusside. You have to be brave when you're using nitroprusside in some patients with acute pulmonary edema, because if you have a patient with ejection fraction of 15% and the systolic blood pressure is 80 and the patient is still not doing well, the best medicine to pull in that situation is nitroprusside. But you cannot leave the patient bedside. You have to monitor everything yourself, because if you do, the patient's going to crash and the patient's going to die because you're not going to treat the patient well. All right, so, and acute coronary syndrome, again, nitroglycerin and esmolol is probably the best. So, all right, for preeclampsia or eclampsia, again, labetalol, you can use hydralazine, you can use nicardipine, but labetalol is probably the best. Stay away from ACE and ARBs. You don't want to use any of those. If the patient have any preoperative hypertension after the operation, blood pressure goes to the roof, nitroglycerin is good. Use nicardipine. Pheochromocytoma, just remember P, phentolamine, PNP, okay. So you have to know a little bit about hypertensive emergency. Hypertensive urgency, you just make sure, why is the patient pressure elevated all of a sudden? Are they taking their medicines? Do you need to adjust the medicine? Are they taking some other medicines that cause the pressure to go up? So you just sit down and take the history. But hypertensive emergency, then that's different. You have target organ damage. Patient need to be put in the intensive care unit. You need to use IV medicines. Anyway, so when you have atrial fibrillation and hypertension, because majority of your patients with atrial fibrillation do have hypertension, okay, and there's increased risk of thromboembolic phenomena, strokes, LV dysfunction, heart failure, and there's increased mortality. So, you have to treat them. There are a few studies that show that HARBs, okay, HARBs were beneficial. As a matter of fact, a number of studies have shown that HARBs are beneficial in preventing atrial fibrillation. So if you have a patient who is hypertensive and they increase risk atrial fibrillation, then you can probably treat them with HARP to prevent the atrial fibrillation. What about valvular heart disease? Your patient with, say, aortic stenosis Your okay, so your patient with aortic stenosis, um, you're going to treat their hypertension. I came across a cardiologist who was not treating patients with aortic stenosis and hypertension. I don't know where you got that directive from, but anyway, so you're going to treat the hypertension, but you're going to start with a lower dose and you can gradually titrate upward, but you're going to treat the hypertension. Very important though, patients with aortic insufficiency, you want to try and avoid beta blockers. And the rationale for that is, remember, aortic insufficiency is a diastolic phenomenon. So anything that prolongs diastole will make the aortic insufficiency worse. If you slow the heart rate, there's more time for diastolic filling. And it's not uncommon for patients who have aortic insufficiency, significant aortic insufficiency, and you start beta blockers and they feel worse. They may go into heart failure. So be careful of that. You don't want to use beta blockers in someone with significant aortic insufficiency. So if the patient have any type of say aneurysm, beta blockers is reasonable. And again, the rationale for that is the shear force, dPdt. You want to lower the heart rate as much as possible to reduce the shearing force. Pregnancies. So pregnancy is a vexing topic because you don't have a lot of leeway. If you have someone who is hypertensive and they become pregnant, you have to transition their medicines. And you can put them on either methyl dopa, nifedipine, and you can use diltiazem too, or labetalol. Okay? So you don't want to leave them on their ACE and or HARPs because that can cause problems in the pregnancy. You don't want to do that. So I think we have exhausted hypertension, and I deliberately stretch it out over 5 lectures because we usually give this lecture in 45 minutes. So just imagine how much stuff we water down and we totally neglect. And